Hi, everybody, and thank you so much for joining the Chest Journal Club webinar. I am Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota, and I'm one of the social media editors for the journal Chest. I would like to welcome the authors for the study Prevalence and Outcomes of Previously Healthy Adults Among Patients Hospitalized with Community-Onset Sepsis. They're going to be talking to us about their findings and how the idea to do their study came about. Dr. Rhee, would you mind introducing yourself for our listeners?
Yeah, hi, I'm Chanu Rhee. I'm an infectious disease and critical care physician and an associate professor at Brigham and Women's Hospital and Harvard Medical School, and happy to be here.
Thank you. Dr. Alrawashdeh, do you mind introducing yourself?
Yeah, my name is Mohammad Alrawashdeh. I am postdoc fellow at Harvard Department of Population Medicine, and I'm also an assistant professor at Jordan University of Science and Technology. I'm glad to be here with you today.
Thank you so much for joining us today. I'm going to start with my first question for both of you, and I would like to know what motivated you to look into this data and to do this study.
Okay, I might start just talking about this. So first, I would like to thank you again personally, Alice and Melanie, and to thank the Chest Journal for arranging this meeting and give us the chance to talk about our study. So as you know, sepsis is a leading cause of death, disability, and costs to the healthcare system. Despite its high burden, awareness of sepsis among the general public, lay media, and policymakers have traditionally been low. However, over the past decade or so, devastating cases of sepsis in previously healthy people, including children, young adults, and celebrities, have received widespread attention and helped to catalyze state and national mandates to improve sepsis detection and care. For example, take the sad and tragic case of Rory Staunton in New York State, where this boy scraped his arm during a school basketball game. Long story short, later he went to the ER and was sent home with a diagnosis of gastric flu. A few days later, Rory died from sepsis. According to his parents, they had never heard the word sepsis, as many of the general public do. However, fortunately, their efforts led to the adoption of a new mandate in the state of New York for early diagnosis and effective treatment of sepsis. That is being said, although these types of cases received a lot of attention, there have been little data on what a fraction of adults who are hospitalized with sepsis actually fit this profile of being previously healthy. Numerous previous studies have demonstrated that the importance of comorbidities in terms of developing sepsis and dying from it. But again, almost none, to our knowledge, have focused specifically on those with no comorbidities. So we undertook an analysis to better understand the prevalence of previously healthy status among patients hospitalized with sepsis and how their outcomes compare with those with comorbidities. This is in an aim to help provide context for high-profile reports of sepsis-associated deaths in previously healthy patients, and also potentially help improve sepsis recognition, the quality of care, and understanding the prognosis of this very important population.
Thank you so much. That's fantastic. Dr. Rhee, do you have anything else that you'd like to add?
No, Mohammed summarized the background and the rationale perfectly, so that was great.
I love it. And what would you guys say is unique about your study design, and why did you choose the specific design that you did?
Maybe I would just start talking about this and then hand it to Chanu. So basically, our study recruited like a really large amount of data in order to answer this question. So we conducted a retrospective cohort study of adults admitted to 373 US hospitals between the years of 2009 and 2015. And the sample was drawn from three non-overlapping data sets that are collectively representative of the US hospitals. And due to HIPAA regulations and other restrictions, and since we cannot merge these data sets, we used meta-analyses for descriptive analysis. And we used a more complex study level meta-analyses for our prediction models, as described in the literature. Another unique thing about our study is the use of the CDC adult sepsis event criteria, which was developed by Chanu Rhee, my mentor, and I would hand it to Chanu, who can talk about this much better than me.
Thanks, Mohammed. Yeah, and certainly don't want to claim sole credit, obviously, for that. Obviously, the CDC adult sepsis event definition, certainly the product of a lot of collaborations over the years with academic partners and of course CDC. But just to talk a little bit more about that, that was a unique aspect of our study, I think, to use this method to identify sepsis in our large data sets. And we did this as opposed to using administrative data or ICD-9 codes or ICD-10 codes, which is a typical method for identifying sepsis retrospectively in these large data sets. And, I think, we did this because there is a large and increasing body of evidence demonstrating the limitations of administrative data when it comes to identifying sepsis. And that includes, relatively low sensitivity, at least compared to standardized medical record reviews. Importantly, there is a lot of variability in diagnosis and coding practices. And those diagnosis and coding practices, we know, are changing over time. And that applies to methods that use sepsis, what we call explicit sepsis diagnosis codes, so sepsis severe, sepsis, septic shock, septicemia. Some studies also use what's called implicit methods, so looking for discharge diagnoses for infection and organ dysfunction. And that increases sensitivity, but that's also limited by variable and changing thresholds for diagnosing organ dysfunction. And also, when you look for concurrent infection and organ dysfunction codes on discharge, there's no guarantee that they were related to each other temporarily or even certainly causally. And so the CDC definition is based purely on clinical criteria. So it's agnostic to ICD codes. It was designed to mirror sepsis 3 criteria, but really more optimized for consistent application across diverse electronic health record systems. And specifically, it looks for patients who had evidence of presumed serious infections, which is defined by the fact that clinicians drew a blood culture, regardless of whether it was positive or negative, and administered at least 4 consecutive days of antibiotics. Fewer than 4 days of antibiotics are allowed if the patient dies or is discharged to hospice or transferred to another hospital. And then during the window, sort of a concurrent window looks for markers of organ dysfunction, things like new initiation of vasopressors, mechanical ventilation, elevations in lactate, or changes in baseline creatinine, bilirubin, and platelets. And so, there have been a number of validation studies showing that the specificity it's not perfect, but it's comparable to sepsis diagnosis codes. The sensitivity is better, and it gives you more stable estimates, across hospitals and over time. And I think for this particular study, we also felt it was important to use this definition as opposed to sepsis codes, because of the possibility that sepsis might be differentially diagnosed in previously healthy versus those patients as opposed to those with comorbidities. The last thing I'll say about the definition we used is that we focus specifically on community-onset sepsis cases, which is defined really by all the CDC criteria happening within the first 2 days of hospital admission. This is sort of the majority of hospitalized sepsis cases. And we were interested in what's happening to patients in the community. And maybe I'll turn it to Mohammad if you want to talk about our method for defining patients with comorbidities versus those who are previously healthy.
Yes, sure. Thank you, Chanu. Yes, this was also another strength for our study with the definition of the previously healthy group and those with comorbidities. So the story starts with our aim to do that and to define the two groups. So in order to define the comorbidities or previously healthy status, we used ICD-9 discharge diagnosis codes. We initially considered using the standard Charlson and Elixir methods that are widely used in the literature. However, when delving more deeply into these methods, we realized that they are not necessarily the best for what we are trying to accomplish, as they were designed more for mortality prediction rather than comprehensively identifying chronic conditions. For example, for the ICD-9 based methods, which is similar to what they use also, which is the method that they both used in both definitions. They are missing many important chronic comorbidities like leukemia, cystic fibrosis, and congenital immunodeficiencies. On the other hand, they included some diagnoses like fluid and electrolyte disorders that probably reflect more on acute rather than chronic conditions. So basically, the way these two scores were designed, they don't match our intention. So therefore, we went line by line down all the ICD-9 clinical modification codes in the AHRQ clinical classification software and identified major comorbidities, for example, heart failure and malignancy, like that impact patient's life tremendously, and minor comorbidities such as uncomplicated hypertension, benign neoplasm, etc. So we identified these based on their likely impact on patient health. All these comorbidities have to be chronic and not acute, and we considered pregnancy as a separate category since it is a temporary condition, but is an important one with respect to sepsis risk. We then identified all the community-onset sepsis patients by the CDC criteria and divided them into previously healthy, who have no comorbidities, versus those with comorbidities. We also conducted sensitivity analysis using other two definitions. A broader definition for the previously healthy that included not only the no comorbidities, but also included the minor comorbidities or pregnancy only. And in this way, we excluded those with major comorbidities. And we also used a narrower definition that included only relatively young patients without any major comorbidities. By young here, we mean less than 60 years. In addition to the crude prevalence rates and clinical characteristics, we evaluated the association between the previously healthy status and the short-term mortality, adjusting for demographics, infection site, and severity of illness on admission. So basically, these were unique things that we used in our study that we think would put something in you, like in the literature, and guide future studies. I hope this answers your question.
Maybe if I can, the last thing I'll say about the methods is just the outcome of Mohammad mentioned short-term mortality. We define that as in-hospital death, but also discharge to hospice. And, we thought that was important because, I think, it's sort of intuitive, but a lot of studies really focus on in-hospital death. But, there are a lot of patients with sepsis who are discharged to hospice. And, while we're learning more about sort of that outcome in that population, what we know is that most of those patients do end up dying shortly afterwards. So I think if you're trying to capture short-term mortality, that's another important outcome to consider.
Yeah.
Absolutely. And I thought you did a fantastic job explaining all of this also in your methods on the paper. And I thought it was a masterful way of, like you both said, trying to take into account, one, that sepsis definition changed during the time that you had your data collected and abstracted. And basically, the most important thing for us at bedside is the clinical picture, right? So I thought it was masterfully done.
Thank you.
Of course. And okay, now about results. Tell me about the results of your paper. And I want to hear from both of you if you were surprised at all about what you found or not, and why.
Yes, basically we were like a little bit surprised by a few things. Some of our results like went hand in hand with the literature. Some of them were surprising. I might just guide you through this like a little bit. Then I would give the chance like to Chanu, like, to summarize everything. So like around like 6.7 million adult hospitalizations were screened or analyzed in this study. They were mainly from the South, medium-sized hospitals, non-teaching. Only just a small fraction, like around 5% or like 338,000 hospitalizations had community-onset sepsis. May I please just ask you just to go to the first figure, please? Okay, so in this figure, we can see a bar graph showing the prevalence of comorbidities in hospitalized patients with and without community-onset sepsis. So those with community-onset sepsis are on the right and those without are on the left. As you can see, the percentage of previously healthy patients in those with sepsis was very small. Actually, that was about only 2.6% compared to 6.2% in the other group. Also, when you look at those with community-onset sepsis, you can see that they have much more major comorbidities compared to the other group. So this was not that surprising, knowing that these have sepsis, like they're more likely to have comorbidities, and mainly major comorbidities. Could you please just go to the next figure, please? So here I would focus for now on the right side of the figure, and we can come later to the left side. So in the right side of the figure that shows the prevalence of different comorbidities among patients with sepsis, we can see how prevalent these comorbidities are. The top three that comes here were anemia, hypertension without complications, and diabetes. So this lets what the amount of comorbidities in this group. Okay, can we please just go to table number 1? Yeah, so and this table shows the characteristics of patients with community-onset sepsis. And here we are comparing those with comorbid conditions, again, with the previously healthy group. An interesting thing is that the Charlson and Elixhauser scores were much smaller in the previously healthy group. So this tells us that our definition goes hand in hand with these definitions in the literature. Also, we can see that the previously healthy group that they were younger. So that was on average 9 years younger than those with comorbidities. As for the gender distribution and race distribution, they were comparable. And by the way, in this table, you're going to see most of these comparisons to be statistically significant. However, we will focus more on the clinically significant ones. So let's move maybe to the next page of this table. Yes. So at the top here, you can see clearly that the previously healthy group has less ICU admissions. However, when we looked at the ICU length of stay and hospital length of stay, they were comparable between the two groups. Looking down into the CDC organ dysfunction that was associated with their sepsis, we can see that the ventilation source was much less in the previously healthy patients, but this group had a little bit slightly higher rate of vasopressors use. If we look at the bottom, like at the infection diagnosis, and we extracted these from using ICD-9 codes, we can see that the previously healthy group having lower rates of infections, such as septicemia, bacteremia, pulmonary, and genitourinary infections. Can we go to the next page, please? Yeah, if we go here, like down to the bottom section for the discharge disposition, we can see that the previously healthy group had a slightly higher short-term mortality. So that was about 22.8% compared to 20.8% on the left side for those with comorbidities. And by short-term mortality, again, we are defining that here as death in hospital or discharge to hospice. However, the previously healthy group, they had lower discharge to subacute facilities, but more discharge to home. Can we go to the next table, please? Next slide. Yes. So for this slide, we looked at the positive blood culture pathogen findings for patients with sepsis by the comorbid conditions and previously healthy again. And both groups showed similar profiles with regards to the pathogens and to the pathogen types. That's in the next page, please. Yeah, so they had similar pathogen profiles. So there was nothing interesting like when comparing these two. Can we go to the third table? Am I rushing through this? Okay, so this
Not at all, you're doing great.
Thank you. So in this table, we looked at the predictors or the risk-adjusted multivariate model for short-term mortality in patients with sepsis. So in the top row here, you see that the previously healthy group, after controlling for everything else, like demographics, severity of illness, and also the sources and types of infection, after controlling for all of these, it's still persistent that the previously healthy group are at higher risk of mortality compared to the comorbidity, comorbidity group. And this was very interesting. Actually, the odds ratio here is about 1.99, so they're about twice likely to die from sepsis when they get it. Could you please just show the next two? Because these are the variables that we controlled for. So these are the severity of illness variables, and on the last page you can see the port or type of infection. I just want to take you back like to figure 2, please. Could you please just go to that slide? So when we looked on what types of comorbidities that put patients at higher risk of dying from sepsis, as you can see here on the left side of this graph, the top 5 were failure to thrive, solid cancer, stem cell transplant, chronic liver disease, and hematologic malignancy and dementia. So these were the top 5 that increased the risk of dying from sepsis. And by the way, when we did the sensitivity analysis using other definitions, the one we talked about in the methods, with the narrower and broader definitions of the previously healthy groups, we got very similar results. Actually, when we used the broader one, that bumped raised the prevalence of the previously healthy group among these sepsis patients or patients with sepsis from 2.6% to 3.9%, but still the odds ratios for that was 1.32. So they're still at higher risk of dying from sepsis. Also, when we used the narrower one, like when we focused mainly on the younger ones, like to be previously healthy, that decreased the prevalence of the previously healthy group from 2.6% to, as far as I remember, that was 1.something%. So that was 1.3%. Yeah, and the odds ratios for that was still around 2. So however you look at this definition, it's still showing that the previously healthy group are at high risk of mortality. That's it for me. Like I would leave it maybe to Chanu just to summarize these results.
Yeah, that was a great whirlwind through a lot of different tables and figures, but that was
Thank you.
great and easy to follow, I think. So I guess I would just distill it down into two major findings. The first is that the vast majority of patients who are hospitalized with community-onset sepsis have pre-existing comorbidities. But previously healthy patients who do develop sepsis and are hospitalized with it appear to be more likely to die compared to patients with comorbidities. And so, with respect to the first finding, as Mohammad said, not necessarily surprising. We know from prior literature that, generally speaking, sepsis is a primarily disease of the elderly and those with comorbidities. I still think, our findings, I hope, are helpful in sort of, trying to quantify, the burden of sepsis in this previously healthy population. And I also want to put those numbers in the context of sort of the overall high incidence of sepsis. So even if we say less than 3% of sepsis, occurs in previously healthy adults, let's consider that the CDC estimates that about 1.7 million adults are hospitalized annually in the U.S. And this is pre-COVID times, but this is important. And that would translate then into over 40,000 previously healthy adults being hospitalized with sepsis, and around 10,000 deaths per year. So that's obviously quite a lot when you look at it that way. And also when you consider that there's a lot of work showing that prior work showing that previously healthy adults or children for that matter who develop sepsis, even though they survive, they go on to have impaired quality of life, more healthcare utilization. So the overall burden is actually quite substantial. With respect to the second finding about the higher crude and risk-adjusted mortality in the previously healthy patients, obviously I think this was sort of the more novel and surprising, at least, finding, because it just goes against, I think, what we would probably guess to begin with. Well, let's talk more about that in a second, but I want to also caveat and just make sure that folks don't misinterpret our study. We're not saying that healthy people in general are more likely to die from sepsis, right? Because our study focused on patients who were hospitalized with sepsis and not looking at the general healthy outpatient population. Clearly healthy patients overall are less likely to develop sepsis and die sort of when all comers. And so I think that's an important thing to consider with our findings.
To me, the way I had it in my head, and please correct me if I'm wrong, since I have both of you here, was if someone who tells me like I had nothing before and I had a scratch in my arm, based on your study, what it's going to do for me is that I'm going to pay more attention to those patients because I know they have a high chance of dying, and perhaps is because as a clinician before I was like kind of like half assured they're like, oh, they're healthy, they're gonna do well, as opposed to someone who comes with cancer being treated or receiving therapy or receiving immune therapy, then I'm already like kind of paying a little extra attention because I know they are at higher risk of having septic shock from a gram-negative bug, for example. So I think to me, what your study did was put an extra level of attention to people who are considered previously healthy, because it might be that their sepsis is so severe and evolving so quickly that they needed a hospitalization, when majority of healthy people who have an infection don't need to come to the hospital.
Yeah, I think that's really one of the important, takeaways and implications of the study that, that really to highlight to clinicians and the public that sepsis, can affect anyone, even healthy individuals, and really emphasize the importance of, having this under differential and treating it aggressively, no matter sort of the underlying substrate. But maybe this is a good segue to talk, I think about, some of the reasons why you hinted at some of them there in terms of sort of how providers care for these patients. Why we might have found that previously healthy patients, have a higher risk of death when they do develop sepsis. Mohammad, you want to start off with some of the theories that we had in the paper? Oh, you're on mute.
Sure. Yeah, I can't agree with you more. And yes, I agree. Like, this population, we don't want to scare the public out there, but yeah, because our study findings, they're more generalizable to those who are in hospitals. That's the first thing. The second thing is that this group of previously healthy, they are less likely to get sepsis, but once they get it, they might have worse outcomes compared to the comorbid ones. So I agree with you, like on that part. So the finding that previously healthy patients with sepsis being at higher risk of short-term mortality was a surprising one, actually, and begs the question of why that might be the case. In our paper, we discussed a few possibilities. First, the first one that we discussed, that the previously healthy patients might wait longer to seek hospital treatment for sepsis and therefore might present with a greater severity of illness. Whereas patients with comorbidities may be more closely followed by healthcare providers or just are more used to seeking medical attention in general. So in our study, this is supported by the slightly higher rate of vasopressor use on admission in the previously healthy group. This is indicative of sepsis shock, which is the most severe manifestation of sepsis. So we interpret that as that they waited longer in order to come to the hospital. But on the other hand, the previously healthy group tended to have overall lower rates of organ dysfunction on admission, as we saw in the previously in the tables. So this raises the possibility that worse outcomes might be mediated by differences in how these patients are treated. For example, sepsis diagnosis and treatment may be delayed in previously healthy patients if clinicians presume that younger and healthier patients are less likely to have sepsis, or if clinicians are less aggressive about their care since they presume they have a better prognosis. We have certainly seen anecdotal examples of this, very famously and tragically with the case of Rory Staunton in New York that we discussed earlier, where he was sent home from the ED with a diagnosis of viral gastroenteritis, when in fact he had sepsis from streptococcal infection. Another possible interpretation is that worse outcomes might occur if healthy patients tend to have more unusual infections or infections without a clear source. Another well-publicized and tragic example of this case is the case of Gabby Gallo, a 5-year-old girl who died from sepsis after developing Rocky Mountain spotted fever that was initially misdiagnosed as tonsillitis or viral infection. In our cohort, there was a higher rate of sepsis without a clear infectious diagnosis or discharge. Although rates of bacteremia and the distribution of pathogens was similar in the healthy versus comorbidity groups, as we discussed earlier in here. So I will leave it to Chanu to talk about another possibility that comes from maybe the use of the adult sepsis criteria. So Chanu.
That's great. Those are great potential clinical explanations. And one is also just thinking about the methodology and how we identified our patients with sepsis. I talked a lot about what I think are the strengths and the advantages of the CDC definition, but because it does rely on clinical markers of treated infection, you have to consider could that be affecting the results somehow? And one possibility is that if providers just tend to have a lower threshold to be concerned about possible sepsis in patients with comorbidities, and they're more likely to order blood cultures and give antibiotics, which then triggers the CDC criteria. And if that happens for less severely ill patients compared to previously healthy ones, that could potentially lower the apparent sepsis mortality rate for patients who have comorbidities. So that's one thing to consider. But I think the clinical explanations that Mohammad put forth are really important ones. I guess ultimately I would say, I think it's certainly a limitation of our study that we have limited insight into the mechanisms, by which the previously healthy patients who presented to the hospital with sepsis, had worse outcomes. I still think it's an important finding. I think in some ways our study is hypothesis generating. I think we would both advocate strongly for all these potential explanations to be thoroughly investigating using very rigorous studies.
Oh, absolutely. I do have a very specific question about one comorbidity that caught my eye when I was reading. Is that okay if I ask? Like, it's very specific.
Yes.
I was very surprised about the arrhythmias and conduction disorders being as like a worse outcome if you came in with community sepsis. I'm wondering if it's a consequence of severe sepsis and septic shock instead of like the presentation, you know, like I find it hard to wrap my head around, okay, someone who has underlying atrial fibrillation does worse with sepsis as opposed to someone who developed atrial fibrillation from sepsis. Does that make sense?
Yeah, I can take a stab at that. I totally hear what you're saying. I guess I would say, so you know, we did our best when we looked at the comorbidities line by line to sort of distinguish ones that were, you know, clearly acute versus ones that sort of indicative chronic. And I'd have to look at the precise codes, you know, specific for these arrhythmias. But you're absolutely right. I mean, there's some possibility for misclassification. So it's possible that some of them, you know, actually were, you know, acute conditions. And just like you said, yeah, we know that if you have sepsis and you develop, you know, AFib or, you know, certainly ventricular arrhythmias and things like that, yeah, it's obviously you're gonna, you know, that's gonna be, you know, a poor sign. But, you know, I can certainly also buy, you know, patients who have underlying, you know, AFib or other arrhythmias. You know, I mean, I think clearly, you know, that is also associated with, you know, other sort of, you know, comorbidities and conditions that would predispose to death. So my guess is probably a little bit of both, you know, for that particular comorbidity.
Yeah, that makes perfect sense. It's just like when I was reading it caught my attention, I'm like, huh, is this before or after they developed sepsis? You know, it just caught my eye.
I think the other top ones really made a lot of sense to us, like failure to thrive and the cancers.
Yeah.
And
like absolutely. All of them make sense to me. It was just the arrhythmias. I was like, huh, okay. Like CKD makes complete sense. Failure to thrive for me actually made complete sense because this person is probably ill for a while, having failure to thrive for whatever reason. So baseline is already chronically ill, right? So it made perfect sense to me. It was just the arrhythmia. And another explanation that I also had when I was reading your paper was maybe these patients with underlying arrhythmias just can't generate enough cardiac output and cardiac index when they are sick because of the arrhythmia. But then again, that was me just going down a rabbit hole of arrhythmias and sepsis. So not the point. So tell me, is your clinical practice going to change in any way, shape, or form based on your results?
From methodological perspective, although we use like large data, but it's still like data extracted from electronic medical records, it still has its own flows. So I'm not sure like that we can move it like actually to practice. But again, as Chanu said, this is more like of a hypothesis generating for a more rigorous studies, I think, in the future, rather than taking this mainly into practice right now.
Yeah, totally agree. And I want to be cautious, you know, about sort of the potential implications. But I think the IV provider in me and the antibiotic steward, you know, is worried about sort of taking this to the other extreme, saying, well, hey, anyone who comes in the ED, you know, with anything must get, you know, broad spectrum antibiotics and treated for sepsis. And then I think that can open us up to another, you know, world of problems. And that's, you know, constantly a struggle, I think, for all of us, you know, who practice medicine and certainly focus on sepsis, is that balance between, you know, early recognition and appropriate treatment, you know, versus, you know, overtreating. And, you know, I think that's going to be constantly be a challenge for us. And so I guess I would just kind of say again that maybe not necessarily this changing my immediate clinical practice, but I think, you know, for sure, again, highlighting to, you know, clinicians and the public, again, that sepsis can affect anyone, you know, even if you're previously healthy. And again, just, I don't think any of us can argue with the general tenets that, you know, early sepsis recognition and treatment, you know, for all patients is important, even while understanding, you know, that in practice that can be often very challenging.
Absolutely. For me, what's going to be is I am going to use this particular figure that we have showing now more in my head to talk to families and patients about prognosis, to be honest with you. And like I said before, for me, like younger patients who come in previously healthy, like examples you gave before, someone who had a scratch in school, a runner who was running and bumped into something and now has a new bruise or something like that, a new scratch. I'm going to pay probably extra attention to these people more than I used to before, in the first 24 hours at least, just to make sure that I'm on top of them, top of like their care. And last thoughts from both of you on your paper and what you like to see moving forward in the community sepsis world.
Mohammad, any final thoughts?
So my initial thoughts was just to design a more rigorous studies, like for the future, like program of research, with more rigorous designs, such as, for example, like cohort study where we just collect the data by ourselves, like not extracted like from the medical records, or for example, like RCTs, which is, I think, I was trying to wrap my hand around this, but it needs more thought. Chanu, do you have any ideas?
No, exactly. Just again, I hope this will stimulate, additional investigation, while also again emphasizing that message that, sepsis, is a huge problem and affects, those of us who are, young, old, previously healthy, those with comorbidities. And, I would say that's really the takeaway message for me.
Absolutely. Thank you so much. On behalf of Chest Journal, I really appreciate your time, and I'm so thankful you came and talked to us about your paper. I thought your paper was fascinating. I thought your methods were very well done, and I learned a lot from both of you. So on behalf of Chest Journal and the American College of Chest Physicians, I want to thank you both for coming in today, and thank you everybody for listening.
Thank you so much for the opportunity.
Thank you, Alice. Our pleasure. Thank you for having us.